Kamal Dessouky. Comparison of free breathing 3D milidexon with single breath hold.
اسمع حضرتك يا دكتور. حضرتك انت كنت جاي مكسره تمام؟ ريهام طارق، ريهام امير، تمام؟ هي دي دكتور ريهام امير. تاني واحده في السيشن.
اوكي الشاشه كده مش باينه، ممكن اعملها فول. اوكي
تمام.
باينه. اوكي. Good morning everyone.
First of all, I'd like to apologize for the delay and the shift in the location of this presentation. So for all attendees, this was the second presentation beginning at 9:06 a.m. I'm very sorry for the delay. Shifting gears a little bit, we'll be talking about late gadolinium enhancement MRI. Today we'll be comparing free breathing 3D MXM with single breath hold inversion recovery sequences, which is basically the simple inversion recovery and the spectral pre-saturation inversion recovery for the assessment of late gadolinium enhancement. Of course, my name is Riham Amir. I'm a lecturer of radiology at Zagzag University. So, to begin with, we all know that late gadolinium enhancement cardiac MRI is the current imaging standard for the detection of myocardial fibrosis. While 2D inversion recovery sequences require multiple breath holds to acquire full heart coverage, for using 3D sequences, we can make this into only one breath hold duration. However, this comes with a compromise. We always compensate spatial resolution and splice thickness to obtain shorter acquisition times. The more recent 3D Ericsson late gadolinium enhancement sequence has some advantages which we can retain, namely the higher signal to noise ratio, which can be traded off to allow shorter acquisition time, and we could also manipulate the spatial resolution capabilities to perform a free breathing navigation technique without the need for breath hold altogether. So the aim of this study was to evaluate the technical and diagnostic performance of 3D Ericsson versus the conventional sequences such as the 3D inversion recovery and the 3D spectral pre-saturation inversion recovery in the assessment of late gadolinium enhancement. So basically we had 78 patients which have performed all three sequences, and we evaluated these three sequences in each patient for technical and diagnostic performance criteria. And we used two readers to do this evaluation. Regarding qualitative scores, we graded from 1 to 4, 1 being the best quality image and 4 being the worst quality image. And we used also quantitative signal to noise and contrast to noise ratio assessments. And we compare these using the three sequences. So qualitative comparisons were measured using Friedman and Wilkinson Sutherland tests, and qualitative comparisons were made using a one-way law. Reader agreements were tested using Collins Kappa, and any p-value more than 0.25 was considered statistically significant.
So regarding results, we actually had to exclude about 19 patients from our diagnostic cohort due to poor image quality, so motion artifacts are still an issue. Reader agreements were excellent for the three sequences in technical quality assessment. Regarding diagnostic performance, the 3D MDixon really shined. So it showed a higher diagnostic confidence in the diagnosis of peri and epicardial enhancement on 3-sequence comparison and on comparison alone with 3D inversion recovery and 3D spectral pre-saturation inversion recovery sequences. 3D MDixon also outperformed the 3D spectral pre-saturation inversion recovery in both the visualization of the late gadolinium enhancement and the quality of fat suppression. So let's look at some examples. The first case here is a 37-year-old male with suspected pericarditis, short axis images, inversion recovery, spectral pre-saturation inversion recovery, and 3D MDixon. The first one, if you realize, the inversion recovery did not show any evident contrast enhancement. The spectral pre-saturation inversion recovery showed a very, very mild heterogeneous pericardial enhancement. Same with the Dixon. We actually had to look at the axial MDixon fat map and water-only map to confirm this contrast enhancement. So as long as you find contrast enhancement underlying the fat, if it's separated, then we can confirm that this is in fact a late gadolinium enhancement. Okay, our second case was a 48-year-old male with a history of non-ST segment elevation myocardial infarction. The visualization of the anterolateral left ventricular late gadolinium enhancement was scored as excellent for the inversion recovery and M-Dixon sequences and good for the spectral pre-saturation inversion recovery sequences. Looking closer between the inversion recovery and the M-Dixon, we find that we can see actually a little bit more detail in M-Dixon. And this is actually pretty critical if we're taking the decision of revascularization in this patient. Because in the M-Dixon, we'll grade it about 75% of the wall thickness, while in the inversion recovery, we'll probably grade it a little bit more. Third case is a 21-year-old male with suspected myocarditis, short axis inversion recovery, spectral pre-saturation inversion recovery, and M-Dixon sequences showed epicardial anterior wall enhancement. This was also confirmed in in-phase M-Dixon and water-only maps, increasing the diagnostic confidence. To conclude, free breathing 3D M-Dixon is a diagnostic problem-solving tool, especially when we're in areas where we have fat in addition to the contrast enhancement. So this is where it really shines. And we can actually make isotropic voxels using the M-Dixon sequence. So that is another huge plus with regards to spatial resolution. The choice of late gadolinium sequence overall should be based on the patient's breath hold ability, the institutional availability, and considering the strengths and the limitations and your clinical application in the end. Thank you all.
Thank you so much, Dr. Reham.